everyone, and welcome to her notebook. Today we are talking about stress with a focus on prenatal maternal stress. I am very excited that we have the opportunity to speak with Dr. Marci Lobel. Dr. Lobel graduated from Harvard University with an undergraduate degree in psychology and social relations. She then went on to obtain her PhD in social psychology from the University of California in Los Angeles. Currently, she is a distinguished professor of social and health psychology at Stony Brook University in New York. She is also the director of the STAR Lab, the Stress and Reproduction Laboratory, where along with an accomplished team of scientists, she investigates how prenatal maternal stress influences birth outcomes. In her research, she has collaborated with an international panel of scientists and has published many articles in peer-reviewed journals addressing critical public health issues, including racial disparities in birth outcomes, psychological aspects of infertility and assisted reproductive technology, and rising rates of surgical delivery. Welcome to her notebook, Dr. Lobel. We are very glad to have you with us today.
It's my pleasure to be here. Thank you.
So to get us started, would you give our listeners a brief history of why and how you decided to focus your work on stress, primarily prenatal maternal stress?
Well, in fact, this research career was somewhat serendipitous. When I first began my training, my doctoral training at UCLA, my advisor had been funded to conduct a study. She was funded by the March of Dimes to examine the impact of maternal stress on birth outcomes. And honestly, the research literature at the time was very disappointing, which is ironic given that pregnancy is a universal phenomenon. I like to say when I speak about pregnancy that it's not something that all of us want to experience or even can experience, but we are all here on this planet because someone decided to become pregnant. And when I began doing that research and looking at the literature, I saw how scientifically weak it was and how it was filled with many, I'll say, misconceptions and myths about women and about women's health. I'll give you an example of that. Some of the early literature on nausea and vomiting in pregnancy, which of course are very common symptoms that pregnant women experience, especially in the first trimester. The literature on this topic suggested that that represented women's attempt to reject their pregnancy. Which of course we know is silly, right? It's not scientific. There were other things that were disturbing about this literature. And so with the support of my doctoral advisor, Dr. Christine Dunkelstetter, who just recently retired, by the way, after an illustrious career, I began to examine stress in pregnant women in a study that was predominantly conducted with Spanish-speaking women in Los Angeles, many of whom were undocumented, many of whom came from very difficult life circumstances, and they were interviewed by bilingual interviewers throughout their pregnancy. We developed some instruments. I'm using the word instruments to explain what are really paper and pencil tests, if you can think about them that way, questions that have been validated on large numbers of people so that we can interpret their responses to items that ask about how anxious they're feeling during their pregnancy, that ask about the specific reasons why they might be feeling worried or tense or anxious or stressed. And our first study, which was published the first parts of it were published in 1990, was one of the most rigorous studies ever conducted that really confirmed that high levels of stress that are experienced chronically throughout a pregnancy elevates a woman's risk of delivering a baby early, which means before the normal 40 weeks of pregnancy. So I'll just, as an aside, mention that preterm birth is defined as any birth less than 37 weeks. And also chronically high stress during pregnancy elevated women's risk of delivering a low birth weight infant. Even if they had gone full term, even if their pregnancy lasted the normal 40 weeks plus or minus 2 weeks, those babies also were more likely to be born at low birth weight, which is defined as any weight less than 2,500 grams. And to give your listeners an idea of what that weight is in grams, it's about 5.5 pounds. So when I talk about this research, I remind audiences to think about what it feels like to hold a bag of sugar or a 5-pound bag of flour. We're talking about babies that weigh very little. And the reason why we care so much about these outcomes, both in being able to predict them and hopefully to prevent them, is because these infants are very vulnerable. They are more likely to die during their first year of life. They are at risk of all kinds of respiratory illnesses, neurodevelopmental problems. And then we see that some of those problems even persist into childhood, into adolescence, and even into adulthood. So adults who were born at low birth weight or preterm also have higher risks of certain diseases, especially diseases of the cardiovascular system. That's referred to as the fetal programming hypothesis or phenomenon. So there are lifelong consequences of preterm birth or low birth weight, often referred to as prematurity. That's, I think, the more commonly used term by the public, but it's not the medical term.
It's fascinating research. I want to take a step back though, because just for the sake of defining things for our audience. So you've described prenatal stress as distinct from general stress. Can you talk a little bit about the differences between the two and also the tool that you developed to measure the prenatal maternal stress? I think the prenatal distress questionnaire.
Yes, yes, I'm really glad that you asked that question because I've spent a lot of my career working on ways to improve the conceptualization and the measurement of prenatal stress. So just to give you a very quick history lesson, in the study of stress, there are really two major approaches historically. One was to think of stress as all of the things that happen to us, the major events, the life events that happen to us, the death of someone that we care about, or the loss of something during a critical period. That's one way of thinking about stress historically. A second was to examine the ways that people feel. They're usually measured in the form of anxiety. So you might think of those approaches as capturing what we refer to as the stress stimulus or the stress response. And it wasn't until about the 1970s or 80s that psychologists began to think about the important distinction that not everyone experiences the same events in the same manner. So what is stressful for you might not be stressful for me. So at that point, psychologists began to think about stress as involving what is called appraisal, thinking about how does this event affect me? How do I feel about it? What resources do I have to cope with it? All of that is well and good. And in our first study, we looked at the major stressful life events that women experience during their pregnancy. We also measured that response component that I mentioned, women's levels of anxiety. And what we found was that, in fact, the combination of those was the best predictor of those adverse birth outcomes that I told you about earlier, preterm birth and low birth weight. Now, I know that that sounds quite complex and sophisticated from a psychological perspective. Nevertheless, it was a better way of capturing all that goes into stress, because stress is not just what events occur, it's not just what we experience, but it's how we think about what's happening to us. And no one had really used that very rich conceptualization and way of measuring stress until we began to show in our research that the combination of those factors is really what increased women's risk. And then in about 10 years after that or so, maybe a little bit earlier in the late 1990s or so, mid 1990s, it occurred to me and to some of my students and others that I train in my laboratory that for pregnant women, we were really missing the potency of what is unique about being pregnant. And what might be uniquely stressful about pregnancy includes things like worries about the changes that our body is undergoing, concerns about our physical symptoms. Are they normal? They might be different than what a woman experienced in a prior pregnancy, or what her sister experienced, or what her friends experienced. Women are concerned about how they're going to pay for their medical care. That's especially a great concern now as Congress is removing some of the supports that our country has previously provided to people for healthcare costs. But concerns about the health of the fetus. Is the fetus developing normally? What about our health behaviors? These are other concerns that women have. Maybe they didn't know they were pregnant and they had some things to drink during the first month of their pregnancy. And then as pregnancy progresses, we see that women become understandably concerned about the labor and delivery. How painful will it be? What will it be like, especially if they've never had a child previously? Will they be able to get help alleviating their pain? What will that process be? How long will it take? Who can come to the hospital with me? And just as a tangent there, we conducted a very large study of women who were pregnant and giving birth during the pandemic. And as stressful as pregnancy is under the best of conditions, I would like your viewers to think about what it was like for women who were pregnant during that global emergency, when they might have ended up going to a hospital to give birth where they could not bring a companion. Many hospitals were not allowing partners, mothers, sisters, or anyone to come with a woman into a strange labor and delivery suite where the people caring for them were covered in complete PPE, wearing masks and suits. That must have been, I'll use the word traumatic for some women. And then to be sent home just hours after giving birth because hospitals were trying to reduce the possibility that women or their newborn might contract COVID. So, and then going home, the stress continues because if you had elderly parents, you might not have wanted them to come to your home and risk them being sick or infecting yourself or your baby. So being pregnant and giving birth during the pandemic was an especially stressful time. And we showed in our research that stress was higher for pregnant women during the pandemic, did increase the likelihood that they were going to have these adverse birth outcomes that we've been talking about. And that was especially true in disadvantaged communities who are already dealing with all other kinds of stress and who may not have had access to the best health care or the best resources at the time. We also confirmed the same kinds of impacts in other countries. So we collaborated with scientists in 6 other Western countries, including, I try to remember to say them in alphabetical order so that I don't leave anyone out, but I may not get that. Let's see, it was Germany, Italy, Poland, Spain, Switzerland, and Israel. I did miss one. We found the same patterns of effects in those countries as well for women who were pregnant during the pandemic. But just, I want to circle back to your question, which was to ask about the prenatal distress questionnaire. So we developed this instrument, that's the proper term for it, which is a set of 17 questions that women are asked during their pregnancy, and typically a clinician, a healthcare provider, or a researcher would ask those questions repeatedly, maybe at every prenatal visit, maybe once every trimester, asking women about the kinds of things that created distress for them. What were they worried about? Did it include the things I mentioned earlier? Changes in their body, changes in their relationship with other people, worries about paying for things, concerns about the baby, concerns about labor and delivery and the birth itself. And women's scores on that instrument, on the prenatal distress questionnaire, were used to predict the likelihood that they would experience preterm birth or low birth weight. And we showed in some of our studies that that kind of distress that's very specific to pregnancy itself was at least as potent, as powerful in predicting those outcomes compared to more general or generic forms of stress. So it's a really valuable instrument if you think about it. Just when you go to your doctor's appointment or you see a nurse midwife, you don't want to sit there for half an hour being asked lots and lots of questions that a psychologist is going to analyze. The beauty of having this instrument that contains only 17 items is that it can be done quickly, that the healthcare provider can then look at a woman's answers to those questions and say, gee, I see that you are especially concerned about this topic. Let's talk about that. Let me see if I can get you some resources to help with that. So it can be used as a clinical tool and then can be used to at least anticipate the likelihood that that a woman might be at risk. So that's the prenatal distress questionnaire. We've revised it. We now lovingly call it the new PDQ, NUPDQ. That's the common term. And it's been translated into, oh, I don't know, I would say somewhere between 50 and 100 different languages. It's being used around the world. In fact, just this morning, I got an email from an investigator in China who wants to translate it into one of the dialects that's common in his part of China and wants to use it to study women there because he's reporting that levels of stress are really elevated among women in that part of China as well.
Yeah. How close are we to implementing this questionnaire routinely in prenatal care? And what are barriers? What are some of the barriers that prevent us in doing so?
Yeah, that's a great question. You know, one of the disadvantages of our healthcare system is that we expect our providers to be able to work very quickly and to see a lot of patients in a short period of time. And in some healthcare systems, there are actual disincentives for spending too much, what they consider to be too much time with patients. So they may actually track the number of minutes that a healthcare provider spends with their patients, and that can be linked to performance reviews and other such things. So to answer your question, one problem is there is just insufficient time given for those interactions with a healthcare provider. A second is that I believe our healthcare providers are not sufficiently trained in how to ask the questions and then how to deal with the responses. So in some of our other work, we've been studying women who have addictions to substances, including opiates, alcohol, cannabis, other substances that are very harmful for women in pregnancy. They're harmful for us even when we're not pregnant. But what we found in that research is that some of the healthcare providers are actually, they're kind of embarrassed to ask the questions. They don't know how to ask. They feel uncomfortable bringing up those topics, and then they don't know what to do with the information once they have it. So we've actually developed another instrument for use in healthcare settings that women themselves respond to, and it can be done digitally on someone's cell phone right before their appointment. And healthcare providers really like that because then they just kind of get a score. Sadly, that means they may not be having those conversations, but at least they can then refer a woman to perhaps a social worker who is involved in their hospital or in their medical center, or to refer women for care by a specific provider, some OBGYNs who specialize in the care of women with substance use disorders. So those are two of the barriers. A third that I'll mention has to do with some of the racial disparities that we haven't had a chance to talk about yet, racial and ethnic disparities. The United States has what I would call a very shameful record of disparities in adverse birth outcomes, especially for African American women, where not only are these outcomes more common in newborns, but also we have an epidemic of maternal mortality, deaths of women during the period leading up to birth and especially right after birth in the first weeks postpartum. And those problems have been very carefully studied by many of us who care about medical issues, behavioral issues, and essentially they can be attributed in large part to the stressful lives that many women of color experience in the United States. In collaboration with one of my former doctoral students, we've done some research on what we call gendered racism in pregnancy. And what we've found is that women of color, particularly African American women who are pregnant, experience unique forms of discrimination. Unique forms of discrimination that women of color who are not pregnant do not report, and particularly white women, whether they're pregnant or not, do not experience. So their levels of stress are elevated prenatally. And without recognizing that they are at higher risk, we know that they're more likely to experience some of those consequences, some of the medical birth outcome consequences. So having a healthcare provider, circling back now to the issue that you asked me about, having a healthcare provider who really understands your situation, in fact, who might resemble you in their appearance, to be a person of similar background, racially, ethnically, and to be a woman would be especially helpful. You know, I always say representation matters, and that's true in the healthcare setting as well. And studies have confirmed that pregnant women of color receive lower quality care when they are not treated by a healthcare provider who is of a similar background as them. And I don't think that this is intentional, right? We talk about overt forms of discrimination. It's not overt, it's what we would call, what psychologists refer to as implicit racism, implicit discrimination. I don't think the healthcare providers are intending to give poorer care, but the result is that perhaps because they don't feel as comfortable having those conversations, maybe they spend less time with their patients, that all of that contributes to a poorer quality of care.
It's very interesting. And you mentioned so many different things in terms of the care, the difference in ethnicities, the difference in a background. I want to come back to some of that, but I want to jump to something that I've read in your 2018 meta-analysis study, that large study that was done, because I found it so interesting and I think very eye-opening conclusions. I really want our listeners to hear about this. So would you talk a little bit about how does emotional distress influence the success rate of artificial reproductive technology? And just for clarity for our listeners, talking about artificial reproductive technology, referring to techniques that assist with conception. So for example, in vitro fertilizations and things like that. I thought that if you could just give us a little brief summary of that study and the conclusions that you found.
Yes, it's an important topic because I think all of us have had the experience where someone tells us, oh, my friend or my sister was trying to get pregnant and she and her partner were experiencing infertility. They went to see infertility specialists. They went through all of the technology. They went through IVF. None of it was successful. And then when they stopped trying, that's when she got pregnant. And the assumption is that something about the stressfulness of that experience reduces the success. And I have to remind people when they tell me stories like this, that for every story that they hear, such as the one I described, there are many, many, many more of people who stop using artificial or assisted reproductive technologies who don't get pregnant, right? But those instances where stopping the treatment, I'm going to say works. I'm putting that in air quotes. Your listeners can't see my air quotes. Those are very memorable. They're very salient. People tell those stories. So we think they're much more common than they actually are. They are not very common. And so it was important for us when we tackled this topic to look across the literature at all of the studies that have been conducted on this topic. And that's what meta-analysis is. So for your listeners, just a very brief lesson. Meta-analysis is a technique where you look at the published literature. You can also include unpublished studies, but we only focused on published studies that had undergone peer review, meaning that we know they were well conducted, rigorous studies, and looking at the pattern of effects across all of those studies. So we can be much more confident of whatever we learn from meta-analysis because it's not just one study. It's the result of many, many studies on the same topic. And when we conducted our meta-analysis on this topic, we found, in fact, that emotional distress does not reduce the likelihood that assisted reproductive technologies like IVF would be successful. So we dispelled, hopefully, the myth that women are often told, just relax. In fact, we titled our article something like, just relax, you'll get pregnant. Honestly, I don't remember the exact title of the article, but it was something similar to that. And after we published that article, I just want to tell you the number of emails that I received from women, and even just people who knew me, who would stop me or call me or send me a message of relief. I remember a phone call with one woman where she was in tears, tears of relief, because she said that for years she had blamed herself, that the IVF was not successful because she was so anxious and tense during that experience. And she blamed herself. And after reading our article, she felt finally, she understood that it was not her fault. So I feel like that was a very important contribution to the many women who undergo IVF or other forms of assisted reproductive technologies who think that it's their responsibility emotionally to make sure it works, to be successful. And of course, that's not true.
Yeah, so I really wanted to hear you say that because I think you're debunking a huge myth. I think it's something that myself included. I did hear the exact story that that you referred to, where they were trying, and then they just stopped, and then and it's that story sticks. And it's so nice to know that scientifically speaking, it is not the case that it has a negative impact on the in vitro, whatever other methodology. So thank you for doing that research. That's very enlightening. So I wanted to ask you on that, what does that teach us about our mind-body interventions? What do you think that should teach us?
Well, I wouldn't give up on trying to alleviate stress, even if we showed that stress was not the culprit in some of the health problems that people have, because of course, stress has its own impact on our lives in other ways as well. Now, that said, there is a lot of evidence across many topics that stress is a contributor. It actually makes us more vulnerable to viruses. I don't know if you're aware of the fact that now you do have to be exposed to a virus, but we're more likely, for example, to catch a cold if we're exposed to someone with a cold when we're under high stress. And stress has been shown to contribute to the prognosis of people with very serious chronic illnesses. So alleviating stress can have numerous health benefits. And we know that there are better and poorer ways to cope with stress to alleviate some of those impacts. So I referred earlier to the fact that substance use is very dangerous in pregnancy, that it can be dangerous in many contexts, that it's not a healthy way to cope with stress. We consider that to be a form of what psychologists call escape avoidance. And there are other escape avoidant behaviors like sleeping a lot or really just trying to avoid whatever the context is that is creating stress for someone. And what we show in study after study is that using that way of coping doesn't reduce distress and it can have other harmful effects. What does seem to be beneficial for many people, not all people, and each person is different, is finding ways to cope constructively with one's stress. And that might be to use healthful behaviors. Exercise is a great stress reducer. Exercise has a lot of other benefits, health benefits. So that's one. Social support is a very helpful way of dealing with stress. Reaching out to our friends, reaching out to our partners, reaching out to our family members, asking for help when we need it. Having someone to talk to, having someone to support us in times that we're experiencing difficulty. Those are all much more healthful and helpful ways to cope with stress.
Right. So I want to ask you, I'm going to come back to some of these coping mechanisms, but I wanted to ask you something else that I also saw in one of your recent studies, and that's with perceived risk versus actual risk. So there was a study that you did that showed that pregnant women's perception of risk, not just their clinical risk, was more strongly correlated in predicting birth outcomes. Can you explain why perception matters so much in shaping the outcomes? And what does that suggest about how we communicate risk during prenatal care?
Yeah, I think that capitalizes on two topics that you and I have already discussed. One is the possibility that women perceive themselves to be at risk because of things they were doing that they had not shared with their healthcare provider. So maybe they were occasionally having a cigarette or using alcohol or doing things that, forms of physical activity that maybe their doctor had told them was not safe for them. So that's one possibility. So they may have known more about their situation than their healthcare provider did. So that goes back to what we talked about earlier, the importance of having a very good, open, supportive, and collaborative relationship with our healthcare providers. And by the way, we did another study which showed that women who had better rapport, better lines of communication with their healthcare provider, actually took better care of themselves during their pregnancy and had lower levels of anxiety. That was a study that was done with midwives. It wasn't done with physicians. But nevertheless, it clarified and confirmed the importance of having good communication with your healthcare provider. So I think one reason why perceived risk was powerful in that study was because those women had insight or knowledge that their healthcare providers didn't. A second could be, and we don't know, so this is really just a hypothesis, that women's perceptions of their risk might have been associated with, back to the topic of stress, might have been an indicator that they were under stress. So if they perceive themselves to be at high risk, they probably were experiencing tension, anxiety, worry, discomfort, and all of those emotional manifestations of stress. So in a sense, the perceived risk factor might have been like an indicator or a proxy for stress in those women.
Interesting. So there's another aspect, which is there's a lot of messaging, especially in social media, about advanced maternal age. What does the science actually say about age-related stress during pregnancy? And how do you think how could they navigate these concerns without creating additional anxiety?
Yeah, that's also an important question. When I teach classes to undergraduate students who are somewhere between the ages of 18 and 25 or so, and I teach about reproductive health, I often ask them the question, when do you think that your reproductive capacity begins to decline? And usually they guess 30, 35, 40, sometimes 45. In fact, the truth is that our reproductive capacity actually begins to decline in our 20s. Now, this is not to say, and I'm also very careful to tell my students, I'm not suggesting that they all run out and get pregnant, right? Pregnancy is something that we hope we do when we choose to do it at a time in our life when we are best equipped financially, psychologically, medically, etc. Nevertheless, when researchers have talked about this in the past, sometimes they've been castigated because of the belief that it's not feminist to tell women the truth about when our reproductive capacity begins to decline. In fact, I believe it is totally consistent with feminist values to share with women the truth about our bodies and to make us aware that as we get older, in fact, the risk of not being able to get pregnant, the risk of miscarriage, and the risk of problems with a pregnancy increase as we get older. There's no magic number. Healthcare professionals often use a cutoff. They used to use a cutoff of 30 or 35. I think that that's gone out of favor. That's not as likely because it's not a cliff that you suddenly fall off of. But with increasing age, risks do increase. And I think it's just important for us to have that information. That information is a tool that if we know, for example, that our risks are greater, that can encourage us to take better care of our health, to try to counteract any risks that we might have with behaviors that will help keep us healthier during our pregnancy. Eating nutritiously, getting enough sleep, getting the proper amount and type of exercise. That's a topic around which there are many myths. We also did a study looking at women's perceptions about exercise during pregnancy. In fact, if someone is in good physical health, and as long as they have the okay from their healthcare provider, exercise can actually improve a woman's health during her pregnancy. It's not dangerous unless a healthcare provider specifically says, for whatever reason, that's not something that a particular person should be engaged in. But I mention all of these ways of counteracting some of the other risks that we might have.
That's very interesting. That would be actually a very good study for women to know about the exercise during pregnancy. Because I think in a lot of cases, people have a misconception as to how much they can or cannot exercise. But I want to go back to your comment on long-term impact because I find that to be very interesting and also important for people to know. So there's research that you did showed that prenatal stress, as you mentioned, can affect long-term child development well beyond birth. What would you say are two of the most important ways this happens? Is it through biological changes like cortisol exposure or behavioral changes in caregiving? I'm guessing here, I don't know. But what would you say are two of the most important ways that this long-term impact happens?
Well, you're a good guesser because your guess is that it involves some of the biomedical mechanisms as well as some of the behavioral and psychological mechanisms is right on point. I do want to clarify that I have not personally conducted these studies, that when I was describing the long-term consequences of prenatal stress, I was referring to a very large body of research, not all of which comes from my laboratory, of course. So first of all, there is impact on the fetal brain development during pregnancy that has been well documented, and that can help explain some of these impacts. It seems that, I'll oversimplify for a moment. It seems that our bodies preserve the brain over and above some of our other organs. So I mentioned earlier that one of the adult consequences of prenatal stress are diseases of the cardiovascular system. So studies have linked high levels of stress in utero when someone was developing prenatally with outcomes like diabetes and heart disease in adulthood. Those mechanisms most likely involve biochemical pathways. So I'll just say also, stress not only elevates some of the stress hormones, you mentioned cortisol, epinephrine is another, but also blood flow to the placenta has been shown to be decreased in women who have high stress. Fetal activity is also affected by prenatal stress. And so, as is the fetal heart rate. So, studies that have monitored those kinds of effects show that stress may have a very direct impact on the developing fetus that then can really set the stage for later problems. But you also raised the very likely possibility that if you give birth to a vulnerable infant, maybe an infant who was born below the normal weight or was born preterm, you're going to treat that child differently. And studies do confirm that these vulnerable infants are not handled in the same way. They're not touched as often. They're not played with as often. We tend to think of those infants as fragile. So it's not surprising that their mothers, their fathers, their family members, even their healthcare providers, some studies have looked at that, treat them as if they're more vulnerable. It's as if that's a self-fulfilling prophecy, because if you don't stimulate, play with, touch, hold your baby, you can be actually producing some of the vulnerabilities that you're concerned about. So certainly the way we care for vulnerable infants is also another piece of the puzzle that helps explain why we see these later outcomes.
Very interesting. Do you think autism may be somehow correlated with prenatal stress? I have not read that anywhere. I'm just curious. It's not something I've found in literature or anything like that. I was just curious.
Okay, so autism most likely is caused by many factors, and some of them are genetic, some of them involve other medical pathways. We did actually conduct a study looking at, so these were the mothers of normally developing children and children who had been diagnosed with an autism spectrum disorder. And we had the mothers report to us some of their prior experiences during their pregnancy. Now, I'm very tentative when I talk about this research because, as you can imagine, people's memories are imperfect, and this is not what we would consider to be a longitudinal study prospectively, where you measure things during pregnancy and then follow children throughout their lifetime. It wasn't that kind of study, it was retrospective. Nevertheless, we did find that the mothers of autistic children reported higher levels of stress during their pregnancy than did the mothers of the normally developing children. And we published that research in a journal that's called Medical Hypotheses. So that's why I want to be very tentative about it. It's not a finding that has been corroborated by other studies. We do not know for certain whether prenatal stress is a risk factor for autism. We do know that children in special ed classrooms are more likely to have experienced, their mothers are more likely to have delivered them preterm or low birth weight. And since we know that stress is a risk factor for that, that's another way of linking prenatal stress to later outcomes. Even there was one study that looked at the likelihood that people finish high school. And that study also linked preterm birth and low birth weight to the likelihood that someone finished high school and to their performance in high school. So again, no direct link between prenatal stress and performance or completion of high school. But since stress is the risk factor for low birth weight and preterm birth, and those outcomes are directly linked to those later adult and adolescent outcomes, there's what I would call an indirect link.
Very interesting. I want to shift gears and I want to ask you a question regarding policy insight. So beyond the clinical tools, what structural or societal changes, I don't know, parental leave or housing, I don't know, childcare, what do you believe would significantly ease prenatal stress at a population level. So we're going to play a game where if we gave you the magic wand and you were able to implement one change, there's probably many that you could think of, but if you were able to implement one societal change, what would that be to have the most profound impact?
Well, that question is kind of like asking a mother which is her favorite children. So I'm gonna demur and say that I can't come up with one, but it is a topic that is very, very important to me. And I'm at a point in my career where I'm spending a lot of my energy and effort working on taking my research into the policy context. We just published an article looking at policy insights from our research. So I am well prepared to answer the question, but I cannot give you only one answer. Let me give you a few answers instead. First of all, having access to high quality health care is imperative for all people, including pregnant women. So universal health care coverage, insurance for all, is something that our country desperately needs. Second, many women report to us their inability to afford high quality childcare. You know, I've been involved in childcare throughout my career. I, in fact, sit on the board of the childcare center at our university. Both of my children are alumni of that childcare center, and that's a topic of great importance. We have a very serious problem in this country with overworked and underpaid childcare workers in access to high quality childcare. And you know, that's where a lot of the development and the learning takes place. So without that important resource, families are struggling to care for children. You know, that was really spotlighted during the pandemic. I think it was one of the times when people realized, hey, you know, it's really hard to care for a child while you're trying to work at your job. Perhaps it was the first time people really realized what a problem it is in this country. Third, we need to reduce the number of unintended, unplanned pregnancies. And the way that we do that is provide better access to contraception and better access to control over reproduction, including when a woman decides that she needs to terminate her pregnancy, to be able to do that safely and legally. We know from many, many studies that unintended, unplanned pregnancies are one of the highest risk pregnancies because people are not well prepared. They may not have the resources to care for themselves. They may not have a partner. The average person and the majority of women who seek to terminate a pregnancy are women who already have another child and who are concerned about their ability to care for that child should they be pregnant and have another child. So typically they lack financial support, they may lack other material support. So if we were to implement in this magical system that you offered me, those would be at the very top, as well as doing a better job training our healthcare providers and diversifying the population of healthcare providers so that we have more people of color who are practicing obstetric medicine, more women of color practicing obstetric medicine, and midwifery.
Are you optimistic that these changes can be implemented?
Well, I tend to be an optimistic person, and the reason why I can be optimistic is because I'm working so hard in my own life to teach about these issues. What we're doing today, I think, is the first step. You have to educate people. We have to inform people what the problems are, what the solutions are. And increasingly, I'm speaking to policymakers and interacting with them. So I try to remain optimistic. I'll be honest, it is very difficult in 2025 to see what is going on in our federal government and to maintain optimism. But I also feel very privileged to live in the great state of New York. and other progressive places in our country that are really leading the way to promote maternal health.
Yeah. I think it's important for people with your knowledge to be able to have these conversations, not about opinion or anecdotes, about scientifically backed information that we all need to hear.
I couldn't agree more, so thank you for saying that.
We're coming to the hour and I need to close. We have a tradition at Her Notebook where we ask our guests to provide some actionable insights that our audience can apply right away. So the question for you is, for women who are currently pregnant, whether the pregnancy was planned or unexpected, what are two practical strategies you would recommend to help manage and reduce prenatal stress during their pregnancy?
Number one, ask for help. Whatever help is needed, figure out who you can ask. I think partners need to be expected to stand up more, but other family members, not every woman has a partner. Other family members can step in, but sometimes people don't know what to do in order to help. So recognizing that we need help, recognizing that it's okay to ask for help is very important. The second is really building that line of communication with our healthcare providers and not being reluctant to tell them if we have concerns or perhaps we've engaged in some unhealthy behaviors. It's very important that they have complete information and knowledge about what we're feeling, what our physical symptoms are, what our psychological status is, etc. And finally, I know you only asked for two, but I'm going to cheat a little and add a third, is just to remember to take care of oneself, that to prioritize ourselves. When we're pregnant, we are number one. So putting ourselves first is something that I would encourage every pregnant woman to do.
And on that note, I thank you all for listening. And thank you, Dr. Lobel, for joining us today and sharing your wonderful insights.
It was my privilege. Thank you.
As we close, I want to thank you for joining me on the Her Notebook podcast. I hope today's conversation brought you some knowledge and sparked new insights. If you enjoyed this episode, I humbly ask that you please remember to click the subscribe button below. Until next time, keep flipping your notebook pages and embrace the journey to a healthier, happier you.